This patient is the middle-aged man, and then just the 2 teeth remaining in the lower jaw. So this is the hopeless tooth. And then this is the immediate denture by the split the tray technique. So with this one, I make some the arbitrary vertical dimension already. And then I take impression just the putty index first, because I want to maintain the same vertical dimension before and after. So putty index making first. And then after surgery, with that one, I will make a vertical dimension making by the combine the vital registration material, the blue mousse. Okay, these 2 teeth, take out. Open wide. Okay. Elevator. Usually lower anterior incision design is a continuous incision. So from the mid-crestal incision, I will find during the surgery mental foramen first. Okay, this is the mid-vertical incision area. This is the midpoint. And then posterior area, Y incision also same. Y incision. And then this is the mid-crestal incision. This is the automatically determined the first molar area, extraction socket area. And then a little bit more distal extension. Also require Y incision for easy flap elevation. For easy flap elevation, I like the lingual flap first. Lingual flap. Lingual flap definitely require full flap elevation. The vocal flap, one by one. I think the full mouth rehabilitation first step is also same, the flap elevation. Usually lower jaw, because for the finding the mental foramen, sometimes the vertical incision is necessary. Today I don't use the digital guide surgery, so at that time we have to use the face midline for angulation guidance. So the same, the patient backside moving, the midpoint area, this is the angulation guidance. This is the angulation guidance. And then 2.2 drill, the 7 millimeter. At the time, please check just the face midline here. This is the face midline. So according to this one, we try to make a first angulation guidance. Let's check one more time. If this angulation is good, I will follow this angulation another 6 implant area. Okay, and then face midline from the anterior view. First one is 14 millimeter, 7 millimeter, 16 millimeter. So at the time, this is from the midline, 14 millimeter, above the 4. This is the canine, and this is the first premolar. Maybe this is the second premolar area, so maybe inferiorly, this is the mental lobe. We will find it together. Okay, this is the mental lobe. So this area, This is the mental lobe area. So this is the maybe second premolar. This is the mental lobe. And then maybe this is the first premolar. This is the first molar area. So this mental foramen. So this is the first molar area. This one. This one. So this area, the marking first. Okay, next one. I will check the first premolar. So let's find together. This is the mental foramen, this one. So this is the first molar, and then mental foramen here. So 7 millimeter anterior. This is the first premolar area. And then this is the canine. Okay. This is the left side. The implant positioning, canine, first premolar, and then first molar area. From this guiding angulation, I follow here, just moving this manner. This is the canine area. I want to keep this the autogenous bone. Okay, moving here. This is a canine. This area 4.0 SQ implant. Next drill 3.5. You can keep the autogenous bone from the drill. Please collect this one. Okay, this is the final drill, the 4.0. Okay, my first implant is the 4.0, 10 millimeter. 보세요. Depth control is also very important, and also initial stability for immediate loading. So you have to feel that around the 30 Newton is necessary. This is your first implant. From the bone, 2 millimeter, at least deeper. Okay, this is the 2 millimeter deeper. And then I will apply the parang pin. This is also the angulation guidance. This is the, okay, this is the second mental foramen. So this is the first premolar area. So I'll drilling here. Also, I will apply the 10 millimeter drilling, the first premolar area. 보세요. This area. Next drill, 3.5. I think the final drill 4.0, because I enlarged the hole for the position changing. Because they always feel the good primary stability for immediate loading. This is the 4.5 SQ implant. Holding here, I can. Good initial stability. Okay, reverse torque for the optimization of the initial stability. Clockwise. Okay, this is the first premolar area. One more check, the mental foramen. Maybe mental foramen is here, so this is the 7 millimeter. We can allow the anterior loop, so it's a very safe area. Okay, this is the first premolar, the implant parallel pin, and then the 5.0 8 millimeter first molar area. So I already marking the implant position of the first molar. You can keep this angulation here with this manner. Next drill 3.5 8 millimeter. You can keep this angulation. Next one 4.0. I think the molar area just a little bit bone density soft bone. So I think the final drill is 4.5 will be better. 4.5. Okay, first molar implant placement. The 5.0 SQ implant 8 millimeter. Okay, good primary stability. Yesterday I commented several times, this kind of the SQ implant, the drilling sequence is well designed already. Okay, from the bone, at least 1 millimeter deeper. So I checked the inferior canal. So maybe a little more deeper is okay. Okay, this one is the optimal depth. So I finished the lower left side already. So this one, I remove this one by one. And then I apply the healing cap. Because suture finished by the healing cap first, and then next one change it to the impression coping. The Dentis impression coping is also well designed according to the emergence profile depth. So I apply the healing cap. Of course, this healing cap changed by impression coping after surgery. Okay, next one. I will check the lower right side. So maybe this is the first molar, maybe this is second premolar area. So grossly, this is the inferior the mental lobe position. Can you feel? This is the mental lobe, this one. This is the mental lobe. So that means I want to change the implant position because the first molar, and then this is the first premolar, and the canine is here. So canine, first premolar, first molar area. So I want the immediate placement at the same time and the canine area. Guidance, just the initial drilling area, this one. So I want to keep this angulation. First drill is the Lindenba and the point drill. Okay, this is the first premolar. This is the canine area, right? Canine. I want to keep the autogenous bone. This is the canine. This manner is very important for the analog approach. Next drill 3.5. Please keep the autogenous bone. Okay, I will place SQ 4.0, 10 millimeter. Okay, very good primary stability. So I check the angulation and I feel the good primary stability. Deep placement, please. Okay, from the marginal bone maybe 2 millimeter deeper. I take out this one. So I will apply the implant paralleling pin for the next implant angulation control. So this is the also angulation guidance. As I mentioned many times, this is the only analog method, right? But this analog method also, without base of the analog method, we cannot go to the next step. The full mouth surgery definitely requires this kind of the analog surgery first. And then at this time, I want to change the lower right side, medial cantilever will be better because this is the initial stability is not proper. So let's check one more. This is the mental lobe here. This is the mental lobe here. So first molar, second premolar, and the medial cantilever will be better. Medial cantilever. This is the mental framework. Okay, this is the second drill, 3.5. Next drill, 4.0. And then this also follow this good angulation, like this manner. Okay. Final drill, 4.5. Keep this angulation with this manner. Okay, 4.5, SQ implant. Okay, keep this angulation. Okay, this is a good primary stability for immediate loading. So this is the premolar area, second. So final process will be the major cantilever. Let's check one more mental framework here. Okay, this is the mental framework. It's a 7 millimeter, very safe. Okay, final area, lower first molar area. I'll remove some of the granite tissue. Okay, I will try the this is the septum area here. I wanna keep the disangulation. Okay, first drill, side cut. This area, I will place the 8 millimeter SQ implant, 8 millimeter. Next drill, 3.5. Just one by one, one by one. Next drill, 4.0. I think the a little bit soft bone. So one step before. Final drill, 4.5. Okay, today final lower jaw final implant. Just 5.0, 8 millimeter SQ implant. Okay, very good primary stability. So I control the depth. In the immediate placement, a little bit deep placement is better. Maybe from the lingual wall, 3 to 4 millimeter maximum depth. I think that this kind of the immediate placement for immediate loading, the membrane with hole for the healing cap technique I will apply. Okay, this is from the drilling, I collected some of the autogenous bone and then mixing with the xenograft. No require the additional the donor site the autogenous bone harvesting. Just packing the gap distance area one by one. Just the grossly packing, just like a gap distance area, and then just the membrane holding by the hole, and then insert the healing cap. This some the resolvable membrane, some the extension. So with this manner, we can make a very simple GBR stabilization. Yesterday, I briefly comment healed ridge area surgery, and then the immediate placement surgery is a big two category for the implant surgery here. Okay, now I'll start the suture. Usually with vertical incision, suture first. Okay, one by one. Simply interrupt suture. So insert a little bit long height, maybe 7 millimeter healing cap height will be better for an easy change to the impression coping after surgery. This patient, within 1 week, I will deliver immediate loading. I think the full mouth rehabilitation is most critical phase is the putty index making for the vertical dimension maintenance. Surgery is not difficult. Just one by one, you can place the implant by the angulation control. Surrounded by the healing cap, I will perform the very precise the knot making here. At the time, surrounding the healing cap like this manner here. So at this time, this anterior simple interruption, I intentionally loose tension right here. This is the second premolar. Still some loose tension for the distal margin of the healing cap. Not too tight. And this area. Please keep the papilla as much as possible, just like suturing for the papilla closure. This is the tension. My finger, please note, maintain the tension here. Okay. Not engage the membrane, only the soft tissue engage, please, for the coronal repositioning. So a little bit. Just the mucosal junction. So maybe some the alveolar mucosa moving to the coronal part, like this manner here. Because the flap closure for the GBL area. I think the lower jaw immediate loading, almost the 90% is available, 90%. Because the bone density is very easy to get for a good primary stability. So, and also for a good management of the patient, so lower jaw immediate loading is very, very significant. Okay, final suture to the Incision area, deep simple interrupt suture. Okay, I finished the lower right side. For impression taken from the fixture level for immediate loading, please finish by the healing cap first. Okay, 2 suture left. Okay, well, final 1 suture. Okay, I finish it. Next one, healing cap removal, one by one. So at the time, please the marking, the record, the healing cap, the sequence. Okay, this is the first healing cap. Change the impression coping. This is the Dentis impression coping. So you place, this is the hex type. So you can place by your finger because you can feel the hex type engagement. And the second healing cap, change it one by one. So this is the second healing impression coping. Also, this is the, you can feel the engagement to the hex. Okay. This is the third healing cap. Fourth healing cap. This is the surgical impression right after surgery. So by the rubber impression, medium body is okay. You don't have to use the heavy body with the light body. Just the medium body is sufficient for the impression taking from the fixture level. This is the before surgery. I make a putty. We just call it putty index, P-index. This is the upper jaw and the lower jaw. And then this is the 4 hours. I make immediate denture. And then this is the putty index before tooth extraction. So with this one, I want to make a vertical dimension. Okay? So this is some of the impression coping interfere with some of the bones. So at the time of the impression coping insertion, please feel the free insertion, free, without interfering with the adjacent the marginal bone area. Okay, number 4. Okay, and then this is the putty index from the before tooth extraction. So I already make this one. And then this is some of the registration after surgery without anything here. I have an upper jaw information with the immediate denture. I have a lower jaw impression taken by the fixture level from the Dentis SQ and SQ transfer coping. I have a bite registration. That means we can make immediate loading. Okay, I finished by the healing cap reinsertion. I really appreciate the patient.